lot. Okay. Anyone still alive? Amir? I'm by myself now.
No, I'm here.
Okay. Ciao, Vittorio.
Beautiful
So we are
talk.
waiting for Amir Dehdashti. He's connecting. I will just give you 1 second to text him. Okay. Okay. Amir, can you turn on your video and your audio, please? Okay. Now I can see you, but we cannot hear you. Okay.
Can you hear me now?
Yes. How are you, Amir?
Okay, very good. I couldn't unmute before. The host wouldn't let me.
Okay. So
Okay, now
Amir
it's
Dehdashti is a great friend, and I'm very happy to have him here, and professor of neurosurgery, Northwell Hospital, New York. So Amir, please go ahead. Thank you.
Thank you very much, Paolo. Thank you very much. I thank you. I thank Sebastian Fröhlich, who involved me in this seminar or webinar. It's good that you talk so much about the anatomy, so I can only focus on the bypass and not going too much around the anatomy. I'm sure we are over time too, so everyone would appreciate if we have a shorter talk. This is what I'm going to talk about. Sebastian told me is really about the vertebral artery outside the brain. So I'm a bypass surgeon. All the bypasses I do usually are inside the brain, most of it, 95%. But of course, we have indications for bypass outside the cranial. And now I'm going to talk about that. I would like to acknowledge 2 people, Fadi Charbel and William Coldwell, really by looking at what they have done with extracranial bypasses, specifically on the posterior circulation vertebral artery. I have learned a lot, and I have to really try to implicate that in my practice. And let's go over the indications. What are the indications really for the bypass on the vertebral artery? The number 1 is vertebrobasilar insufficiency. And this is a variety of area the vertebral artery can have narrowing. That could be from the ostium, starting at the origin from the subclavian, could be complete occlusion, could be very significant stenosis, and then could be higher up. The stenosis of the vertebral could be at V1, V2, and sometimes can extend up to V3, and we don't see anything else. What is very important, and I want you to pay attention, is the muscular collaterals that reconstitute the vertebral artery. This is a very important factor every time that you make a decision regarding a surgery on a vertebral artery that is occluded, because you definitely don't want to, or at least you want to minimize the amount of interference with those muscular collateral vessels. So VB insufficiency is the number 1 indication for us, at least as a neurosurgeon, as a stroke surgeon. What are the other indications that we use the vertebral artery for some sort of bypass? Is when we are dealing with aneurysm, specifically pica aneurysm, vertebral to pica junction aneurysm. Subclavian steal syndrome. This is not something really that neurosurgeons deal with, but it's good to know about it. And also common carotid occlusion. If you have no other way to vascularize your carotid because the common carotid is occluded and the patient has carotid-related ischemia, vertebral artery could be as a very valuable donor in the neck, and is actually better than, for instance, sometimes doing an STA-MCA bypass, as long as your internal is still open, but the problem is the common carotid that is occluded, which means that your internal is getting retrograde field by the external, but is not enough. Then you can just add a jump graft from vertebral to the carotid and basically renew a new carotid from the neck. So the surgical options, this is exclusive. This list is very inclusive. So we're starting from the V1 segment. When do we need, or a surgeon needs to use the V1 segment, which is the before entrance into the foramina? for bypass, and that would be usually, generally, is for aortic aneurysm, is not in the indication of the, is not in the ward of neurosurgeons, but you should know about it. Aortic aneurysm, where the aortic segment needs to be sacrificed or replaced, and we have to do something with the vertebral artery. So the V1 will be used to be mobilized and be implanted on common carotid, and this way you can basically sacrifice or replace that segment of aortic without worrying about the vertebral artery. V2 is the more common area that the neurosurgeon gets involved, and that's the area that can be used for vertebrobasilar insufficiency. And that would be, could be anywhere, any segment in the vertebral artery V2 segment, which is from the transverse foramen C6 all the way to C1. But depending on how the angiogram looks like, depending on individual anatomy, I have usually used the V2 in the C1, C2, C3 segment. That's where we identify and be isolated for bypass. And then you can use radial artery or saphenous vein graft. So at V1, the vertebral artery has redundancy. You can actually bring it up and put it on the carotid. I'm going to show you an example. At V2, you can't do that because it's, yes, it's redundant, but it's not that redundant. So you need to have a jump graft, radial artery graft or saphenous vein graft, and then you connect that to the V2, and then you can connect that to the common carotid or to the external carotid, depending on what type of bypass you want to do and to what vessel. Then we get to V3, which is again used for VB insufficiency as a good indication, and variety of option for V3. For V3, as a matter of fact, you can do the same indication for V2 as well. But for V3, because it's getting further away from the carotid artery, if you're doing a jump graft, one option could be, for instance, going from subclavian or the thyrocervical branch of the subclavian with a saphenous vein graft to V3, which is above the C1. The other option is to use occipital artery to V3 bypass to increase flow in the vertebrobasilar circulation. One caveat here is that we have to be very careful and look at the angiogram very carefully, because occipital artery sometimes is the collateral supply for posterior fossa when vertebral artery is deficient. So if you see a very robust collateral going from occipital artery to posterior circulation, it's not helpful to cut that occipital artery and anastomose on V3, because you cut some collaterals to create a new collateral. So that's something that has to be decided based on individual anatomy. And finally, V3 can be used as a donor for replacement of a pica with, for instance, radial artery graft. Saphenous vein graft can be used too, but radial artery is better because it's a better match. And finally, when we get to the V4 segment, the anastomosis, the indication is rare. I would say only aneurysm in the V4 segment that you want to cut and reanastomose is extremely unlikely, but that's one indication that you can use the V4 segment for bypass. So this is a good overview of all the bypasses that can happen on the vertebral artery. Some surgical consideration before I go through surgical cases quickly. The surgical exposure, Paolo showed very nicely the exposure of the vertebral artery, specifically the anterolateral or so-called extreme lateral approach. One thing I have heard people saying sometimes that they cut the levator scapula to get to the region around the longus coeli and the transverse process. I prefer not to cut the levator scapula. You know, the levator scapula is served by the dorsal scapular nerve, is helping the movement of the scapula. So it's better to work underneath it, and then you can cut the longus coeli and expose the transverse process and get to the vertebral artery. When we do and consider doing a bypass on vertebral artery that is occluded and relies on collateral supply, very important to use the lowest segment. Usually these vascular collateral supplies are higher up, more cranial. So we don't want, and we have to avoid cutting the vertebral artery where there are those collaterals. So you have to be as caudal as possible. As mentioned earlier, keep occipital artery patent. This is very important because occipital artery is a secondary collateral supply to vertebrobasilar circulation, unless the angiogram completely confirms that it's not. And during this procedure, always we give heparinization a little bit more than when we do bypass inside the brain. When I do intracranial bypass, I give 2,000 units of heparin. When I'm doing outside the cranium, 5,000 units of heparin. And all these patients are on aspirin 81 or 325, depending on the pathology. One other very important thing about the occlusion time. Does it matter when we are dealing with VB insufficiency to occlude the vertebral artery? Does it matter? So if the subclavian is occluded and we are occluding the vertebral artery, remember the vertebral artery has a retrograde flow. If the subclavian is occluded, the vertebral artery with the retrograde flow is serving almost as a blood supply to the arm. It's almost like putting a cuff on your arm and inflating it. So anesthesia, when they do that, usually after 45 minutes, 1 hour, they inflate for the blood flow to go back to the arm. So you have about 1 hour if the subclavian occluded. More than that, there would be a risk, not for the brain, but for the arm ischemia. However, if the V1 is occluded and subclavian is open, and then you have cranial muscular collaterals, as long as you're below those collaterals, the time is irrelevant because you have all the time you need to do the bypass because there are collateral cranial to you that contribute to vertebral artery. And when you have the vertebral artery origin and the V1 completely occluded in a dominant VA where is not relying on muscular collateral, that means that you still have a flow going to the vertebral artery, which is the dominant artery, but is significantly compromised. Typically, that would be like an in-stent stenosis, where endovascular team cannot open that stenosis for whatever reason it is, access or anything. Then the patient's brain depends on that anterograde flow, and you have to vascularize above that stent. So that means that your occlusion time is very crucial. It's direct ischemia to the brain. So that, obviously, the occlusion of the vertebral artery should be as short as possible, but usually these are simpler bypass to do. Yes, the vertebral artery is deep, is a deeper bypass, but for a bypass surgeon who does bypass inside the brain, let's say even MCA or in the Sylvian fissure, or like, let's say on 8.3 or PCA, these bypasses are way easier than those bypasses. So it should not take more than 20 to 30 minutes to sew the vertebral artery in an end-to-side fashion. So these are the considerations that I would like you to keep in mind. Now, going to a few cases very quickly. I don't know how much time. I mean, I had said I want to talk only for 15 minutes, so I'm going to go quickly through all these regions to show you the different area of the bypass we can do. This is for V1. So for V1, you can see this is a big aneurysm at the aorta here. And when we are exposing the V1, this is done with a lateral incision over the subclavian region. And what we want to do here, we want to basically expose the carotid artery. This is being exposed. This is the common carotid that is exposed here. And that's pretty easy to expose the common carotid, especially on a thin person. And the other thing that you would like to make sure is the vagus nerve that is just behind it. You want to make sure that the vagus nerve is not damaged, so you can isolate that. And then in the subclavian triangle, you go medially to find the V1 segment. So remember here, what we want to do is we want to get the V1 and disconnect it from the subclavian and connect it to the common carotid. So that segment of the aorta can be treated without worry for vertebral artery and brain circulation. And this is a dominant vert. So you can see here, obviously dominant vert, we have a time issue here. So we have to be done as soon as possible. So you can see this is the vertebral artery that has been skeletonized in the V1 segment. A clamp is positioned distally. The proximal part is being clipped. And then it's a matter of cutting it, preparing the graft for this segment because the vessel is bugged. A 6-0 proline will be used. And this is a punch in the common carotid. And then it's a matter of sewing the vertebral artery to the common carotid as quick as possible, combination of running and interrupted. But these are very big vessels. So sewing on this is relatively easy. So residents and fellows can participate in doing this because these are relatively easy. And you can see this is the end product for the V1 segment. And basically now the carotid circulation participates to the circulation of the vertebral artery to the posterior circulation. Now, we're going to go to another segment. This is a patient, a 35-year-old patient who presents with, look at this, young patient, unbelievable stroke in pica, posterior circulation here. And then we do an angiogram, and you can see the right vert is completely occluded in the V1 segment. I don't know if you see my arrow, but this significant muscular branch from the tyrocervical take over the...
The arrow, Amir.
The arrow is visible?
Yeah.
Okay, perfect. The tyrocervical cervical take over the vertebral artery by the muscular branches. And you can see this is almost at level of the V1. This is on the right side, but the patient also has mainly had a left-sided problem. And you see this is the left vert. The origin is occluded, but then there is muscular branch comes up and contributes to this vert. So there is anterograde flow in both vertebral artery, but there is not enough flow because he is getting a major stroke and he has symptoms of VB insufficiency. And look at his PCOM. He has tiny PCOM on both sides. So none of the carotid injection shows the basilar circulation, which means that this is left, this is right. This means this patient is desperate for flow. So I'm waiting on this patient to get a NOVA MRA to confirm the lack of flow in the posterior circulation. And my plan would be to do what I'm going to show you in the next video, vertebral artery. And in this patient, because left is more symptomatic, but has already much stroke. So my plan is to do the bypass actually on the right side. So I'm going to do a common carotid, radial artery, vertebral artery bypass in this location, just below those muscular collaterals. I said, you never want to go there. So we're going to go and find the V2 segment between C2 and C3. So this is where it is. This is a left-sided approach. Here is exposure, as you know, I think Paolo alluded to a lot of these. We identify the common carotid, you identify the jugular vein, and in order to find the vertebral artery, you work under the jugular vein. And here, we go and open this fascia, the venous plexus that is around the vertebral artery. This is in the C2, C3 segment. You go here and you can identify the vertebral artery, and then there's redundancy. You can pull it back, so you get it out of the space, and then you have your graft here. That is the vertebral artery in the V2 segment is being clamped, and then we're going to open it and do an anastomosis with the graft. For vertebral artery, 8-0 is fine. 7-0 is fine too, but 8-0 nylon is perfect, depending on the size of it. But this vessel here, this is an 8-0, is being used, the combination of running and interrupted. And then once this is done, this is the vertebral artery done, we unclamp, let the graft flow, take the clip off the vertebral artery, and then we let it bleed, and then put the clip back just above the connection. So this way the vertebral artery has its flow for now, and then we go and cut the graft around the jugular, come over the common carotid artery, cut the graft at an appropriate length, and this is the common carotid. The punch or aortic punch is being used, 5 or 4 number, depending on the size, and again a heel and toe of the anastomosis is sewn, and then we connect that with different sutures. So now we have a common carotid, graft, 2 vertebral artery, a good flow is notified, and that will take care of the VB insufficiency. And you can do that also to ECA. So it's not necessarily need to be common carotid, can very well be ECA. This is another situation for the same problem, but here, the other alternative for this is to use the subclavian. So in this situation, the patient needs, this is also in VB insufficiency, bilateral vert occlusion, and this is saphenous vein being harvested endoscopic, and the goal here is to identify the subclavian artery. So it's 2 incision. One is, and you can have vascular surgery help with that because they do that all the time. And then another incision is done behind the ear for kind of a far lateral exposure to identify the C1 in the C1 groove that actually Paolo was showing very nicely. In the suboccipital triangle, you find the vertebral artery, and that segment of the vertebral artery is very mobile. You use a tunnel to pass the saphenous vein graft, cut it at appropriate size, and start clamping the vertebral artery, opening it with scissors, and basically go ahead and do a bypass between the vertebral artery and C1. This is there. And then the V3 anastomosis is done. Unclamp the vert, put a clip on the graft so the vert still has whatever flow is still going through. So you don't want to keep it clamped for too long anyways. And then the graft is tunnelized under the skin. We come to the neck and connect that to the tyrocervical trunk of the subclavian. We don't need to put it right on the subclavian. You can use the tyrocervical. It's a perfect match with this saphenous vein. And that goes in. And then once you open it, basically you have a new vertebral artery, incisions are closed, and this is a new vertebral artery reconstructed with the saphenous vein. Now, I talked about occipital artery, and I want to show you these pictures. You see how occipital artery and the vertebral artery are relatively close to each other. That's a suboccipital triangle with inferior oblique, superior oblique, and rectus capitis posterior major Paolo was talking about. And this is the occipital artery going up, and this is the vert. Look how close they are to each other. So in an ideal situation, you would say, just bring this down and connect to vert, and that will give you, look how occipital artery and vert could be close to each other in this picture. So that's the only downside is that, as I said, occipital artery 50% of the time participate in the collateral blood supply to the posterior fossa, specifically when there is vertebral artery insufficiency. So that has to be ruled out before this be considered as an option. But then we can take the occipital artery, bring it down, and put it on the vert, and that could be a very nice and very, actually, I would say, slick procedure. We can do it with a small incision, where we can follow the occipital artery with a small curvilinear incision, follow the occipital artery from external, go as high as we can, separate it and bring it back. That's one way of doing it. One of my friend and colleague in Idaho, Andre, has done that, and that's a very nice way of doing it. The only problem is that you might have some limitation in terms of length. So the other option is to really harvest the occipital artery the way we do for aneurysm. And I'm going to show you how you should harvest the occipital artery. The best way to, this is a patient with an ICA aneurysm. I'm not going to focus on that. I'm going to just focus on showing you how we harvest the occipital artery. So harvest the occipital artery the same way that we do the superficial temporal artery, from inside out, in a sense that you start from the most proximal segment. This is where it starts just behind the occipital groove, and the occipital artery is identified, and then we just dissect it out and follow it. So this is much more natural because it's from proximal flow to distal flow, and you use Colorado tip around to keep a good fascia around it, and that will give you a very nice occipital artery here. You can see that's the occipital artery you have. You can have the length that you need, and look at this, the flow that you can get, and this is very long and it's perfect. And the vertebral artery here is going to be right there, right where my the hand is. You see this hand? This is where the vertebral artery. In this patient, I wanted to use this occipital artery for ICA, so I really need the length, and I'm going to bring it intracranial. But if it was for extracranial, the vert is right there, so I can just put it there if needed. So that's how I would suggest the occipital artery to be harvested. So in this patient here, this is a patient that need an occipital artery V3 bypass for the VB insufficiency. This is the occipital artery. That's what I showed you, the way it was harvested. And then we'll bring it back. You have the V3 segment exposed, clip on either side, and then it's just a matter of sewing the vertebral artery and occipital artery together. Vertebral artery, sometimes, especially the V3 segment, can have sclerosis and atheroma in the wall. So sometimes you need to do an atherectomy, almost like an endarterectomy. I don't know if the last case I'm going to show has that. Or as long as you can keep the flap and the atheroma inside the suture, then it's fine, because you just need the flow. If there is a little bit of atheroma, it's not that much of an issue. What you don't want to happen is that the area of your anastomosis create a flap with the atheroma of the vertebral artery, and that will occlude your bypass. So that's you don't want to happen, because then it will be very difficult to restore the flow once the thrombus is inside it, or it propagates distally into cranial components. So when this bypass is done here, you have this, and then either side is connected, and it's just a simple extracranial occipital artery VA bypass, and you add additional flow to the brain. So this is also one example. ICG confirms the good flow. And finally, what else we can do with the vertebral artery in the head? This is a patient with a subarachnoid hemorrhage, significant subarachnoid hemorrhage, mainly in the posterior fossa. You can see she already has a very significant vasospasm, has this distal segment pica aneurysm that cannot be sacrificed. Is a major pica. It's on the second segment, lateral medullary segment of pica. This patient doesn't have a good occipital artery. She does not have contralateral pica for pica bypass. is not a segment where side cutting and reanastomosing is easy. Is a pretty significant length, and you can see on the 3D pictures. In this space, you don't have much of redundancy to reconnect the pica together because there are lots of perforators there. So if you do that, you might have a limitation in terms of mobilization. It's very different than if you do an end-to-end at the tonsillomedullary segment of the pica or even telovelotonsillar. Anteromedullary, lateromedullary, you do not have redundancy. So the only option for revascularization, and this is not a clippable aneurysm, you have to sacrifice this segment. The only option here is to use the vertebral artery as a donor, radial artery, and pica as recipient. So here you can see the same thing. This is a right-sided approach. Vertebral artery is exposed in the V3 segment. One thing I want to emphasize, you see all this coagulation around, this is for venous plexus. The venous plexus around the vertebral artery is very robust. Sometimes the bleeding from it almost look like an artery, but it's not an artery, because if you have ever encountered a bleeding from the vertebral artery, you know how it is. And I hope you never encounter, but you know how it is. And those venous bleeding that could at time be pretty serious, it's still very easily manageable. As long as you identify the vertebral artery, you can coagulate and shrink those tissue, and you get to this situation when you have the vertebral artery. And then we have to isolate the vertebral artery. I have used a radial artery graft here, and this radial artery and the pica in the tonsillomedullary segment, and Paddy's is over the aneurysm. And then we go ahead and cut this suture with a 9-0, the radial artery to pica in an end-to-side fashion. And then coming back now to the extracranial and V3 segment, you see here, there is a little bit of atheroma, I believe. You can see here the atheroma. So I'm not doing endarterectomy. What I'm trying to do is to make sure that the atheroma and the flap all is taken together with the suture. And the radial artery has been sewn to V3, like the previous video that I showed, a combination of running. I think here run the whole thing. And then it's a matter of occlusion time. Again, as I said, we want to usually keep it not longer than 30 minutes and should not be longer than that, quite frankly. Even with residents or fellow participating in putting some of the sutures, you back bleed from the distal verts to get the blood out from the graft, make sure that there is no clot anywhere. Back bleed, put the clip back, suture the last tie, and then this is the final product from VA to pica. So extracranial VA to pica, that's the last indication that I showed you. And then we go here and just distal, we clip the aneurysm distally, put a clip distal to the aneurysm, is one way of flow diversion, and that will basically immediately kill the aneurysm. And this clip comes off the pica, and you can see this is the graft from extracranial component. Obviously, during closure, we have to make sure that there is no tension on this thing. And this is the ICG showing the graft is open, and this is the final product with the graft is open, and you can see the aneurysm that was there is not visible anymore because there was a distal clip. The distal clip flow diversion cured the aneurysm, and the graft is taking care of the pica circulation. As last one that I mentioned to you, I don't have any experience with it on the V4. It's extremely rare that we do a bypass, and that would be reanastomosis if you have an aneurysm on a V4 segment. But quite frankly, many of those aneurysms are amenable to endovascular treatment because if there is a need for sacrifice at that segment, usually the other side can take over. But again, those indications are rare for V4 bypass intracranially. That's it for me, and thank you very much for your attention. If there is any questions, I don't know if you want to have a discussion briefly.
Okay, thank you, Amir. Very nice cases. Congratulations. Okay, so Sebastian, we will not be able to, Sebastian Fritsch will not be able to connect. Just send me a message. He's in trouble. It's not in trouble, but he's very busy in the OR, so it's not going to do the presentation. So I think we are done for today, and we will see next month for the craniocervical junction anatomy.